surgical palliative care. And it's my pleasure to introduce to you Dr. Platnick, who's an associate professor of surgery at the University of Colorado and at Denver Health Medical Center. So by way of introduction, he went to undergraduate school at the University of Oregon and then completed his medical degree at the same institution before he did his general surgery training at Kern Medical Center in California. He did a trauma fellowship at St. Paul Ramsey Medical Center, followed by a critical care fellowship at the University of Minnesota. He currently is the director of the SICU at Denver Health Medical Center, but in the past, he's been the trauma medical director there and currently is doing a fellowship in hospice and palliative care at the University of Colorado. Dr. Platnick, thank you.
Thank you, Dr. McIntyre, and thank you for having me here, and thank you for allowing me to speak on a topic that's not usually a surgical curriculum topic. I've completed my fellowship, and I would like to say that I can empathize for all of you that are going to take the boards in whatever field you're going into soon. In our field, it takes 3 months to get the results, and I'm happy to announce that I passed, but it was a drag. My first disclosure is that the objectives that I submitted are not the objectives that I'm going to address today. And my second disclosure, I wonder if this works. Yes. And my second disclosure is that this, as many of my talks are, is more of a call to action than anything. It's fairly difficult to address palliative care, especially palliative care in the ICU, in 30 minutes. And so what I'm hoping to do is really impart to you the need for us to pick it up and run with it. These are my objectives. My objectives are for you to be able to describe primary palliative care, understand really the difference between primary and specialist palliative care and when to consult a specialist, really an understanding what palliative is and is not, maybe more importantly. And something I'm going to spend a little time on is this concept of total pain, which may or may not be new to some of you. And hopefully by the end, we can agree that primary palliative care is a fundamental aspect of surgical critical care and really a fundamental aspect of all the care that we provide. So I'm going to start with my dog Potter. And you can imagine Potter wanting to go on a beautiful vacation. So imagine it's somebody you love dearly wants to go on a beautiful, wonderful vacation, and you love them unconditionally. And they go to a travel agent to book this vacation. But when they finally arrive at their destination, the travel agent actually hadn't asked them where they wanted to go or what they wanted to do. Nobody asked them what they wanted to eat. Nobody asked them who they wanted to be with or even what language they would like spoken. Suddenly, they're terrified and alone. They don't know what's going to happen. They're anxious. They really have no idea what's going to happen. And then they're drugged, restrained, poked, prodded, and find themselves stuck in really what we do to patients in our ICU. So I'm not saying that our patients come to the ICU expecting a vacation, but I'm pretty sure they're not expecting what they get. I want to start with this, which is the American College of Surgeons Statement of Principles on Palliative Care. So this was issued almost 20 years ago. And the reason I bring this up is I want to make sure that we understand palliative care is not an internal medicine thing. It's not a family practice thing. It's an everybody who does medicine thing, okay? You can look here and you can see that nowhere up here is there a reference to actually doing surgery. Okay, we're talking about the rights of the patient. We're talking about the ability for us to communicate effectively. And in fact, interestingly at the bottom, for us to be able to play well in the sandbox with others, which it's interesting that our own parent organization called that out. And then you can see at number 8, and I think this was spoken to a little bit previously, which is our duty to counsel against and discourage non-beneficial therapeutic interventions. This is something we see in the ICU, right? We see patients who are injured, who may have traumatic brain injury or other injuries in which subspecialists may be recommending, what they think is the only thing they have to offer. And we recognize the fact that that's non-beneficial. And it's up to us to be able to recommend to the patient that they not undergo non-beneficial care. So what is palliative care? The death squad, morphine team, who we call to get a DNR, who we call to do nothing once we've done everything? No, it's none of the above. So this has become my new favorite joke on rounds. And I have to be, of course, careful that I'm out of earshot of the patients and the family, but you know, this is what palliative care is not. Okay, it's not the death sentence, it's not the death squad. In fact, palliative care consultation in the intensive care unit either improves mortality or, it decreases mortality or has no change with respect to mortality. It's not just for comfort care or end of life care. They're not addiction medicine. So I think it's important to recognize we're not calling them because we have somebody who has a drug problem. It's not mutually exclusive with life prolonging or life saving care. And it's not just getting the DNR. The message here is it's not a sequel to failed care. Palliative care is not who we call when we've done everything and we think, well, there's nothing left to do, let's call palliative care. Palliative care is something to be delivered alongside of life-sustaining treatment. And it's our job in the intensive care unit to be providing what we'll talk about, which is primary palliative care. Palliative care is, in fact, a multi-dimensional approach to the management of suffering. So suffering is a big topic, and I have a word cloud too. We'll get to it in just a second. I think that's maybe one of the topics for today. It's an interdisciplinary field, and when you consult palliative care, you don't just get a person. Okay, you get a team. And so when we provide primary palliative care, we're not just providing it individually, we're using the resources that we have available to us at our institution. It's patient and family-centered care. And one of the terms that I use is the patient care unit. I stole that from TQIP, Trauma Quality Improvement Program. The patient care unit thinks of the patient and the family as the patient would describe them. So, you know, not everybody thinks of family in the same way. And so it's important that we think of family in the way that the patient does. And that's how I think of it as a patient care unit. We talk about this as a specialty and a practice that we need to perform, which anticipates and treats suffering and disease burden. If we think of burden, the burden of care that we have placed on the patient and that the patient is going through, one of the things that we know is that if we can decrease that burden, the patient is more likely actually to go through with the care. And so it's counterintuitive, but delivering palliative care alongside life-saving treatment and life-prolonging treatments, by decreasing the burden of care, we may actually increase the likelihood that the patient survives and actually continues with the care. Just for clarity, hospice, on the other hand, is not completely different from palliative care. We often draw this distinction: palliative care is not hospice, hospice is not palliative care. Hospice is a form of palliative care, and it's a comfort and quality of life-based care or focused care that's delivered to people who are thought to be in the last 6 months of their life. Importantly, and what I want to point out is hospice care, comfort care, withdrawal of life-sustaining therapy is not doing nothing, okay? It's actually, it may in fact be more intensive than some of the things that we typically do, but we don't think of it as aggressive medical therapy. These are interventions which are aimed at improving quality of life and decreasing symptom burden and suffering. So, primary palliative care, which is what I think is incumbent upon all of us in our fields and specifically in the SICU to provide, is the elements of palliative care that can be delivered without needing to consult a palliative care specialist. And some of this we do implicitly, but some of it I think we need to do maybe more intentionally. And maybe it's actually incumbent upon us as faculty to be teaching it more intentionally. So these things that you see on the list, we do, but we don't necessarily teach, and we don't necessarily think of as intentional components of what we do for a living. That we don't think of this is sort of what we do when we're not doing our real job. This is in fact part of our real job. One of the things you'll notice here is that the only thing that that we see that we think of as traditionally medical is symptom management. And yet I would submit that for the patient and the patient's family, all of these are of great significance. So I don't want to underestimate or understate the importance of symptom burden. So I want to run through this here a little bit. As you can see, we clearly have not got symptom management ironed out in the ICU. When you look at patients who've been in the ICU for 7 days or more, this is what we see. And you'll notice that 2/3 or more of the patients have inadequate control of the majority of symptoms that they experience in the ICU, whether there is a result of their illness or injury, or whether we actually inflict these on them. One of the things that I think is, is sort of startling is that if you think about it, 2/3 of the patients that we put on ventilators that are on full support, in other words, we're resting them on the ventilator, are experiencing shortness of breath. I don't think that we necessarily think of the fact that our patients on the ventilator are experiencing dyspnea. And that's something that we should be inquiring about and something that we should be treating on a regular basis. I wish I had time to drill down on actually any of these as the low-hanging fruits, because you would think that dry mouth, hunger, thirst, et cetera, are things that we should be able to address relatively easily. But in fact, if you survey our patients, this is what they describe when they're discharged from the ICU. So my plea to you is to become experts in the management of these things and to consider these things when you're treating your patients. So when I ask you what suffering means to you, what comes to mind? I wish this was interactive. It's more fun that way. So when you think of suffering, or when I think of suffering, I typically first think of pain like everybody else does, physical pain. And yet, when you take a look at this word cloud, you can see that pain is certainly in there and at the center. And I think physical pain is what we're referring to. But you can also see a constellation of other symptoms or feelings, emotions, or states of being. And these are prominent. And I think what that points out is that suffering is bigger than just pain, and that suffering, in fact, is greater than the sum of the parts. I think not only do I think this, but our friends at the college think this as well. And the ACS Committee on Ethics issued this statement, which is that control of suffering is of equal importance to the cure of disease. And for a group of people who say things like a chance to cut is a chance to cure, I think that that's a pretty impressive statement. And so suffering is at the forefront and should be at the forefront. It's at the forefront of what the patients are experiencing, and it should be at the forefront of what we're addressing. When we talk about suffering like this, it's useful to consider a concept that is referred to as total pain. So, question number 2, which of these things do you think might contribute to total pain? A large burn? Yes. Severe TBI? Rule out neck fash and butt pus consults all night long? Extra night float? None of the above. All of the above. Yeah, all of the above. Depending on who you are and what you're experiencing, your suffering may be directly related to this, and it may be an interplay of all of these things. So total pain is typically described in this Venn diagram, and I've adapted this Venn diagram to speak to our patients in the ICU, and I want to take a few minutes to drill down on this. I think that if you take a look at this sort of from a distance, you can see that it's clear why having a team, not just an individual, to address the suffering of the patient is important. Frequently, we have nursing, and we have chaplaincy, and we have social workers, we have medical professionals, us, but there are other professionals that may be involved in the management of total pain. For instance, child life therapy, depends where you work, child life specialists, recreational therapy, massage, acupuncture, if you happen to be at a place that has that available. So let's just take a look at this, and we'll start with physical pain because I think that's easy for us. Well, I don't know how to move that. We'll start with physical pain because I think that's easy for us. If you look at injury and disease, we know that orthopedic injuries, rib fractures, crush injuries, patients who are status post laparotomy, all experience great deals of physical pain. But our other patients in the ICU also, if you think of our patients with malignancy, not only did they undergo surgery, but maybe they have direct extension, bone mets, non-healing malignant wounds. All of these things are creating physical pain that we may or may not be experts at dealing with. Our interventions, we all know that when we poke and prod patients, we're hurting them. But do we think about the fact that when we're turning the patients or when we're changing dressings, or maybe even when we're examining our patients, it's causing physical pain? Patients with comorbid conditions, they come in with pain. Patients with CHF, COPD, rheumatologic conditions, they have baseline physical pain. And so when you think about our patients in the ICU, they're already experiencing this great deal of physical pain that we are managing. And I would submit that maybe that's something that we need to focus a little more on, and I'll get to that in a second. Our patients are also experiencing social pain. Certainly our trauma patients, but many of our patients who come into the ICU for any period of time may have financial concerns, not just about the hospital stay, but about their missing work. Maybe they're unable to make house payments. The loss of role and social status can be huge. A patient who is disfigured or unable to participate in what they usually do in their social environment is going to experience a great deal of suffering and may be anticipating that. Loss of a job, worrying about family welfare, and we're actually worrying about supporting the family and worrying about having the family have to support them. And then additionally, legal concerns. Then legal concerns may not just be our patients at Denver Health or your trauma patients who are worried about, going to jail afterwards, but maybe legal concerns about writing a will, maybe legal concerns about setting up funeral arrangements. So you can see that a patient undergoing physical pain who is now worrying about all of these other social circumstances has compounded pain. If they then have anxiety about what's happening to them, maybe they're afraid of suffering. Maybe they just had a dressing change and they're worrying about the next dressing change. Our patients clearly have often have baseline depression or maybe develop elements of situational depression. Many of our patients have been recurrent patients, and they've had previous experience. They've been in our ICU before. And our patients are they're all experiencing loss. They're experiencing loss while they're in the ICU, but they may be experiencing loss when they leave the ICU. Our patients who are laying there in bed, experiencing physical pain, worrying about their financial concerns, worrying about the loss of a job, may also be experiencing guilt, shame, and denial. Maybe they did this to themselves. Maybe it's a failed suicide attempt. Maybe it is a result of maladaptive coping strategies throughout their life. In any case, they can be experiencing this, compounding the fact that they have broken ribs or a gunshot wound and are about to go to jail and going to lose their house. And then there's the spiritual layer. The spiritual layer does not have to be a religious layer. You don't have to be angry at God. You may be, but you can be angry at the universe or just angry. Maybe you're experiencing a crisis of faith. Maybe the person is thinking to themselves, how could God have done this to me? Maybe this brings it into question everything that they believe. Maybe they're struggling to find meaning with what's happening to them and how they're going to move forward. And whether it's whether they did this to themselves or not, or how it occurred, they may be fearful of divine repercussions. And everybody is concerned with the fact that they are currently in our ICU having a loss of dignity. And so you can see somebody who's experiencing physical pain, social pain, psychological pain, and spiritual pain has amplified pain. And that's what we refer to as total pain. And it's important for us in the ICU to recognize how severe this can be for a person. And the fact that this is a multi-dimensional assessment of pain and requires an interdisciplinary team to manage it. Now, the interdisciplinary team is going to advance, isn't it? There we go. The interdisciplinary team does not have to be the palliative care team. We have teammates in the ICU. So what are the parts that we do and what are the parts that the specialist team can bring? I think that we recognize that we manage pain, but I think we have an opportunity to probably do a better job and learn to incorporate some novel therapies for pain management in our ICU. They may be SNRIs or tricyclics or whatever the sort of think outside the box management might be for our patients. And other symptom management, I'd be willing to bet that there's very few specialists in the management of nausea here, right? We all throw Zofran at everything, but there are other medications and approaches, non-medical therapies for the management of nausea, and adjuvant pain medications, the use of regional analgesia. These are the things that we do, but we can be more elegant and scientific about it. When it becomes refractory or we're unable to manage it, that's when it's maybe time to get our specialist palliative care team involved. Sometimes we have patients actually who had outside palliative care, and they're already sort of complex to begin with. Patients with addiction or baseline opioid tolerance may require specialist palliative care. They may require addiction medicine, and I want to be clear that they're not the same. So if we're dealing just with managing a substance abuse disorder, that's addiction medicine. But patients with severe pain issues who have baseline opioid tolerance, maybe our specialist palliative care will help us. When it comes to the psychosocial, I think we address it sort of tangentially, but we need to be more direct. That's the elements of primary palliative care that we should be bringing to the table. We should do a basic exploration of this level of suffering, basic exploration of spiritual and religious views. And that really just might mean asking them, do you have spiritual or religious orientation? And would you like some comfort with that? And then bringing in chaplaincy. I'm not suggesting that we're going to be delivering this care. I'm certainly not an expert in everything that was on that total pain slide. But I can address the elements, and then I can find help when I need it. And we should all be able to conduct basic family meetings. One of the things I would say, however, is that I think as faculty I could do a better job in modeling that and demonstrating that and teaching that to the learners. When it becomes outside our comfort zone, it's time to bring in the specialists. And the specialists are a team. Again, I really do want to emphasize, we're not just bringing in a palliative care doctor, we're bringing in a team. Communication issues. One of the things that I think that we might forget from time to time is that our communication is not just with the patients, but it's with the other team members. In the surgical ICU, we can have orthopedics, neurosurgery, cardiology, rheumatology, anybody can be involved in the care of our patients. And sometimes they don't always have the same message. And part of our job is to clarify that for the patient and the family. It's sometimes our job is actually to gain consensus with our own colleagues. When that becomes difficult, or when we're unable to do that, it's time to get our specialist team to do that, because A, we may be struggling with it. B, we may not have the time for it. I mean, that may be the real truth about what's going on for us in caring for these patients. One of the things that I wanted to point out is this idea of making recommendations about code status. Many of us are reticent to make recommendations. It's important to recognize that it's our job to do that. It's not our job to turn the patient and the family members into medical professionals and have them come up with their own recommendations. clearly the recommendations we make are based on our understanding of the patients, and that's why it's important for us to get to know them and to do the background work. One of the other things is that from time to time, we'll get questions about things that we don't know anything about. And that's another opportunity to get our specialist palliative care team involved. In Colorado, one of the things that comes up from time to time is the idea of assisted dying. And, I think that that's an opportunity to bring in a specialist team. Again, more care coordination. That is our role. And when I say our role, that may be the social worker or care management in the ICU. It may not be just the poor resident, although it often is. But it's hopefully we have help in our ICU. When it becomes too challenging or too time consuming, it may be that we involve our specialist palliative care team to help us out. So one of the things that you'll see at Denver Health as house staff, if you come there for the ICU, and for those of you who've been there, is this ACP note. And I think sometimes we're stringent about it. Maybe we don't understand it. I just want to take a minute to go over that. The advanced care planning note. So why is it important? Because we don't get paid without it. It's a tool to drive best practices. We can't go home until it's done. True-ish. It helps us gain a better understanding of the patient. Documentation is just good for the soul. No, B and D are correct. It does drive best practices, and it helps us gain a better understanding of the patient. And that's the foundation for really doing all of the things that are fundamental to primary palliative care. So this is how we do it. This is our standard templated note. And you can see it helps us, it guides us to have a conversation regarding advanced care planning and goals of care with the patient. It guides us to document them. And one of the things at the bottom you'll see is it guides us to estimate the length of stay in the SICU. So trajectories of injury and illness are important for us all to understand. And without a knowledge or a sort of a basic idea of where the train is headed, we won't know when it's come off the tracks. And so we really can't speak to ourselves about what to expect, and we can't speak to the patients or the families. So this really is the groundwork for us to better understand them and help us provide the primary palliative care that I've described so far. So in summary, primary palliative care is not restricted to those at the end of life. It not only can be, but should be delivered alongside of life prolonging care. Pain is not a unidimensional phenomenon. If I could impart anything to you, that it is that. It's that when you are treating somebody who is talking to you about pain, and it seems like it's not being controlled with what you're doing, think outside the box, or actually think around the Venn diagram, because it may be that there's something compounding that also needs to be addressed. And lastly, we as surgeons need to create a fundamental culture change. And I think that it's starting, but it's nowhere near where it needs to be. This is one where inadequate or inappropriate management of pain and suffering, total pain, is seen as being as important as anything else at M&M. And I've actually started to try referring cases to our M&M for just that, for patients who are not receiving adequate alleviation of suffering. So I'll leave you with this. You've got 6 months, but with aggressive treatment, we can help make that seem much, much longer. Thank you.
So I have an observation and a question. The observation is that I've noticed that between medicine specialties and surgical specialties seem to feel more empowered to tell patients that a surgery is futile and therefore will not move forward, whereas medicine seems, in my observations, to be more likely to say if it is technically feasible and the family wants it, well, then we will proceed. Mm-hmm. My question, however, is with regard to palliative surgery.
Mhm.
And the case that comes up probably most often in my practice is a patient with terminal cancer who develops a bowel obstruction, as an example.
Mhm.
And that can be managed either palliatively medically or palliatively surgically, but ultimately the outcome will be death for that patient
Mhm.
either way. How do you think through the role of palliative surgery in patients for whom the ultimate goal of survival is not possible?
Yeah, I think that's a great question. And I think that I would reframe it as me not thinking through it, but me working through it with the patient and the family. And so I think the first thing is to talk with the family about, or the patient, if they're able, sort of what are their hopes and what are they trying to achieve? What are they worried about? And where are they at right now? A lot of our patients will say that they need a little more time. And we have to be able to sort of explain to them or help them understand what that might look like. And if after doing that, that scenario is consistent with their goals, then I think it's appropriate to move forward with that. But I think it's important, to speak with the patient. So a patient who needs to get to their kid's graduation might want a venting G tube. A patient who wants to go home and just die at home, they may need a venting G tube. They might be willing to undergo a surgery, but I think it's important to let them know that they may not make it home if that's what we do. And so that maybe if dying at home is what they're hoping for, the best case is actually some medical therapy and get you home. I think it's all about getting a better understanding of what the patient's trying to achieve, and then making a recommendation. One of the things that I want to impress on people is that when I say make a recommendation, it's not my recommendation about what I would want. It's not my recommendation about what I would want for my parents. It's my recommendation for you based on what I know about you. And that's why it's important for me to get to know you.